actually work here with Leading Home Care. I do the marketing here, and so Leah reached out and wanted to do a body mechanics class to kind of train our DSWs and even benefit some of our client care managers today. So hopefully what they do. So we have Alex Angel. He's with Stat Home Health. Well, they're all with Stat Home Health. So Stat has a really big entity. They'll explain a little bit about what they can do, but today they're gonna show us some body mechanics, some kind of just safety, how to use certain equipment in the home with the patient, one of our clients, and hopefully what they teach us here today can benefit us when we're in the home, just to have a better safety supervision with them when they're in the home, and even just some of the services that they have to offer. Hopefully that we can refer patients to them to kind of just get stronger and maintain the mobility that they have. And so this is Alex with Stat. This is Blaine, this is the PT, and then this is Desiree, she's another rep with Stat. And so they'll show us a little bit, and then for the DSW that is here today, Leah has a time sheet where she'll be passing out at the end, so you can be compensated for your time here today. So thank you.
Alright guys, well, thank y'all for being here this morning. We just wanted to come and introduce ourselves and partner with you guys as far as training you, and we have a good relationship with Tara. So we're all a big continuum of care whenever it comes to our patients. You know, us partnering is good for our patients, so that's why we wanted to come here today and have this in service. So I put a little brochure on y'all desk right there. So the backside has some information on our memory program. Y'all can just go ahead and disregard that. What's more, well, yours is empty, but most of y'all may have this on there, so just disregard that. If you're interested in it, that's another service that we offer. It's for Alzheimer's and dementia, but really what I wanted to show you guys today is how to recognize if a patient is appropriate for some home health services. So just a little bit of background on myself and what I do. I'm from Breaux Bridge. I have a background in physical therapy and sports medicine. I'm not a physical therapist, but I worked in physical therapy clinics, and I did outreach work for the athletes at the high schools in certain parishes. And then I've been knowing Blaine for a while, so my background's in physical therapy, but I got this job once I started having kids, and my wife wanted me to have a job with normal hours. So now I'm here, and you know, I'm still helping people just in a different way. So I have a big heart for physical therapy patients and the elderly population, because I watch my family suffer with it. So that's one of my big passions there. But I just wanted to come and give this to you guys. There's a bunch of bullet points on there that qualifies somebody for home health. I have a bunch of relationships with doctors, I-10 and South all the way to Franklin. That's my area. So if y'all do see a patient that could benefit from home health, you can always reach out to Tara. Tara can reach out to me and say, hey, I have Mr. John Doe. He's he's at a big fall risk, he's having diabetes, stuff like that, and you can tell me what doctor he sees, or you can just give me the patient's phone number and I can just have a conversation with them, and I can go out and if I do have a relationship with that doctor, I can say, hey, I got a call for Leading Home Care, this patient could benefit from some home health, and then I could facilitate getting an order for them so we can have physical therapy, nursing in the home, along with you guys to help keep that patient independently living in the home. So that's just a little bit about me. I'll let Desiree give a little background on herself, and then maybe we can get started with some transfer training.
All right, good morning, y'all. My name is Desiree Ordway. I am stationed north of I-10. So if you or a family member, need our services, I'll be more than happy to help you. I have been in home health and hospice for the last 14 years. I do not have a background in sports medicine, although I did play sports and used sports medicine a lot. So, but that's about it. I've been doing hands-on with patients on the hospice side for quite some time. But I recently came back into doing what I'm doing now. So, if there's any questions you guys have after, let me know. If I can help anybody, let me know too. Thank you.
Hi, my name is Blaine Clark. I've been a physical therapist for 11 years now, mainly with Stat Home Health, working in the home health industry, seeing some of the types of patients, clients that you take care of, and the most important thing is to have safety in the home. Whenever you're moving these patients safely to take care of your backs and your necks to where you don't get hurt and become a patient as well. So you're gonna hear me talk a lot about body mechanics, basic support, to avoid twisting and rounding at the back when lifting these patients. You wanna use your legs, which is the strongest part of your body, and your back. I mean, if you're using your back and twisting is very vulnerable to injury and whatnot. So first thing we're gonna talk about is bed mobility, and then we're gonna move over to transfer, sit to stand, and then fitting of walkers, canes, and guarding when walking and stuff like that. So Alex, go ahead and lay it on your back here. When you're getting so patients laying in bed, ideally you're there because they need assistance. Ideally if they were mod, max assist, a hospital bed would be great because you could lift the bed up to a good working height for you. And a good working height would be anywhere from mid-thigh to about belly button level, to where you're comfortable, you're not bending over, straining your back, and risk getting injured. So this technique to get them up from supine to sitting or laying down to sitting up, I use for a lot of back patients that just recently went through surgery, but I use it in the elderly whenever they require assistance because it's a lot easier on me and more efficient. So what I have the patient do is go ahead and bend both knees. Okay, and then from this point, I'll scoot over a little bit to the left. Okay, and from this point, I could use his legs as leverage to help roll him over on his side. And then from that point, we're gonna discuss, getting up from rolling and sitting up in the sitting position. So what I'll usually have the patient do is I'll have them do as much as they can to avoid, injuring yourself, or if they can do it, great. If they can't, then you're gonna assist them doing it. So I'll have you roll your knees this way. And I like to have them reach across the bed with their opposite hand for the edge of the bed, and we're gonna get them into a sideline position like this. So from this point, we can either do one of two things. If they can lower their legs off the bed, great. If not, you could do it for them and help them out with that, and do it in a two-step process. So usually what I tell them is, we're gonna lower your legs off the bed, and then I'm gonna have you tuck your bottom elbow into your side and put your hand up against the bed there. So if they can lower their legs off the bed for me. Good. You kind of have that leverage to help get them up like that. And then what I like to do is grasp under the top shoulder. That way I can stick my arm underneath the bottom of their shoulder and help assist them up if they need it. And I like to use 3 counts. Everything is
I just had back surgery too.
Yeah, so if we can move together, it's more efficient and avoids injury for both of us. So yeah, go ahead and lower your legs again. So on the count of 3, I'm gonna have you push up with both arms, and I'm gonna come into a sitting position, okay? All right, 1, 2, 3. Any questions? Okay. And then you can sit there. And it'd just be the opposite of to get them down. Once they're sitting, to lay them back down. I would have them lower themselves. You come down on your side, lower yourself on your elbow. Good. And if they could raise their legs onto the bed themselves, great. If not, once they're stable, I could go ahead, bend at the hips and knees, raise their legs, and then help roll them back onto their back. obviously we'd have a bigger bed. Okay, next, transfer, sit to stand. Okay, obviously make sure the chair is locked, and what I like to do is, get the patient all the way to the edge of the surface that he's gonna be transferring from, because it's a lot easier to, have them get up at the edge than it is way back, center of gravity, way back here, you do a lot more work than you have to. I also like to use a gait belt. It's a lifesaver. Helps reduce the stress on my back. The patient, I'm not grabbing under his arms or her arms and risking injury to them. Everybody used a gait belt before, or know how to use a gait belt? Okay, so I can stand in either one of two positions when transferring patients. I can either stand to the front of them, grabbing under the gait belt, what I call is an underhand death grip, versus grabbing on top. You got the risk of it slipping out and something happening, the patient falling, whatever. Or you could stand behind them, same death grip, and help them up that way. Okay, so Alex, go ahead and scoot to the edge of the chair. All right, and I like to tell patients to get their feet shoulder width apart, feet directly under their knees, and I use the cue to get their chest far, because a lot of them want to just lean back, stay back, and you're doing a lot more work than you have to trying to get them up. So if we could get them over here, the center of gravity lessens, and it's a lot easier to get them up. And so if they have a chair with armrests, that's great. I like to utilize those armrests with both hands. If not, whatever surface they're sitting on, I like to push up from there. It is okay, you want to grab that walker? It is okay to have them put one hand on the armrest and one hand on the walker. I never want to have them both hands there because there's no stability. And pulling up from here is coming down with. So, if they have a weaker side or injured side, I like to stand on that one just because I can help them stabilize better to compensate for having that weaker side or injured side. So let's say he's injured on the right side. What I'm gonna have you do is we're gonna count to three, another 3 count. And on the count of 3, we're gonna push with your arms and legs. You're gonna bring your nose over your toes. We're gonna come up into a standing position, okay? And I like to stand in a stagger stance, AP stance, lateral not so much, but more as you can get that weight shift from your back leg to your front leg and just help them transition on the way up. Okay, on the count of 3, we're gonna stand up. Okay, 1, 2, 3. Good. And grab the walker. Any questions on that? And so the same thing with coming back. I like to have them back up. I want you to back up until you feel your legs touch the back of the wheelchair. And then once we're there, you're gonna reach back for your armrest and have a seat. Go ahead and reach back with your hand. Good. Okay. So sometimes the patient has trouble getting to the edge of the chair. So what I like to have them do, if they're struggling doing that, they're gonna push back. If they're in a wheelchair, place a chair with a back, they're gonna push back with their shoulders and kind of use your shoulders to slide your bottom forward. Can you do that? Like that. Good, and then once they're there, we can kind of help them up to come to the forward position like that. That's good for that. Okay, so let's go ahead and stand up. Good. And when using a walker or a cane, I like to fit the patient properly. A lot of times I get to the home and I got a 5'0" lady and her walker's way up here and she's complaining of shoulder and arm pain. So appropriate measurement and height for the walker should be, I like to get them inside the walker. And once they got their balance, I like to let one arm just relax it down by your side. Okay, so I like this top portion of the walker to be right at their wrist. So as you can see, it's a little bit too high for him right here. So I would lower it down to where it gets to his wrist. Feels good. Alright, and then I guess the last thing, when guarding the patient when walking, go ahead and stand on the walker, let's face this way. So I like to stand behind them on one side or the other, preferably the weaker side if they have one. And I'm just gonna get that underhand death grip again, and then we're gonna go for a walk. I like to have the patient stay at the back side, the back bar of the walker. That'd be the appropriate distance. A lot of times they want to have it way out here, and then they're gonna be complaining of shoulder and arm pain or wrist going too far and falling over. So having them kind of walk at that back bar is a good model to have when walking these patients. Okay, and again, if they have a weaker side, I'm on that side, so I do like that. I could have the hand on the gait belt, hand on the shoulder, just walking them like that. Any questions on that? Okay, good.
It's gonna be good.
No, you can take it off. Yep, that's kind of everything for that. Y'all have any other questions about any other techniques that y'all seen, or?
What about transferring the bed, recline from the bed to the wheelchair?
Back to the wheelchair?
Yeah.
Okay. Do they have like a walker or something, or just kind of you trying to just transfer them
Yeah, just
without
trying to
anything?
show the BSWs, cause sometimes some of them, have may have a concern about how to transfer, the proper way to transfer and recline from the wheelchair to the bed.
Okay.
Look at that.
Alright, let's see on the bed here. So when transferring from a bed or another surface to a wheelchair, I like to position the wheelchair at an angle. Right up against them there, not directly in front like some people do, but at an angle. You have less space to travel if you do that. If you have it directly in front of them, you gotta make them turn all the way around, and it's just too much. So from here, we'll just say they have a walker. And this table's a little high, for him, so can you scoot to the edge to where your feet are flat on the ground? Which, in some cases, the bed would be this high, but,
Right.
you know, we'll make do with what we have. So, from here, I'll just have him stand up. Good. And then we're gonna pivot and turn until your back's facing the chair. Kind of turn the walker. And I could scoot over this way. And then you're gonna have him back up to the chair and then have a seat. Go ahead, reach back. Good. If they don't have a walker, you could stand in front of them, but again, I like to stand 1 foot ahead of the other. And I usually prefer my stronger leg in the back. That way I could shift my weight onto it. And if something happens, I need to sit them back down, I can quickly transition to sitting them back down. So let's scoot to the edge of the chair. So I'll cue them on both hands on the armrest of the chair. And then I'm gonna help you come up into sitting on the count of 3. And once you stand up, you can put your arms on my shoulder. 1, 2, 3. Good. And then we'll just pivot and turn until they're back on the bed. I like to have them sit as far back on the bed as possible. Good strength you have.
Good PT.
Any other questions?
So if they wouldn't have the gate open, would just use their clothing, because a lot of our clients don't have a gate.
Yeah, I know. Yeah, I mean, pants are one thing. Sometimes I'm forced to have to use the pants because I don't have a gate belt or they don't have a gate belt. If they're just in their diaper, that may be difficult because they're just gonna rip apart. So before getting them up, I would put some shorts or something. They don't have a gate belt, shorts or pants to use those. Or if they have a belt, like just a regular belt, you could use that as well. I've done that before too.
Now you're gonna have me riding around with a belt in my car. I say, now you're gonna have me riding around with a big belt in my car.
Well, normally they should have one, but yeah.
A lot
I
of
mean,
them don't.
don't have like a regular belt at all.
No, 'cause most of them don't wear.
Yeah. Okay. Well, yeah. I mean, I would invest in like a gate belt for sure.
Yeah.
They'll save on your back, and you know, just doing this, especially if a patient is mod max assist, trying to get them up, you really put a strain on your shoulder.
Right, right.
And if something happens, they lose their balance, you know. They just fall. Yeah, sure.
If y'all wanna try some of the techniques, I'll be your guinea pig if y'all want to.
How I normally would do it, because I've been a nursing aide for 22 years, how I normally do it, I would transfer the client from the chair to the bed from the chair. I normally put my leg in between, like how you did, kind of similar. You know, how you normally my leg. That would be easier for me, and I normally make them, you know, up there. And I would pick up there, no, I'm not gonna stand up. And I would count 1, 2, 3, it would be easy for me, then we will pivot.
That's perfect.
Sit down.
Yeah, good wide. Good wide support.
And there's a difference in height too.
Right.
So it's probably easier for you to do it like that, you know?
Yeah. I just always try to get them to the edge of the chair, versus, you know, back, but everything there look good.
Yeah.
Anything else, or any concerns? But yeah, I would invest in a gait belt. Saves me a lot of headache and, you know, from lifting on the patient, under their arms and stuff.
What about for someone who can only bear weight for about maybe 10, 15 seconds?
assist to get out, when you say?
Basically, yeah.
Do they have, there's no lift in the home?
Right, that's
There
what
is a
I'm
water
saying.
lift.
Yeah, I would resort to that.
The lift,
Yeah.
okay.
If you have a Hoyer lift and they are mod max assist, I would definitely utilize that.
Mhm.
You don't wanna strain yourself way more than you have to. Especially if they're a bigger patient.
You know what I always struggled with was the sliding board. That was my challenging, most challengeable, technique was the sliding board. Because sometimes it wouldn't always work,
That's usually a difficult one because normally the patient doesn't have a hospital bed and we can't get
Mhm.
the height the same. Ideally, you want it, the surface is the same height,
Mhm.
but it doesn't always work out that way, especially if you're having to go up the sliding board. I don't have a sliding board. What are your concerns about it? Like I was saying, just different height or getting up
Just
to-
trying to how to angle the sliding board, because, you have a client that's, don't have a hospital bed, you know what I'm saying, for example,
Mhm.
and, you're trying to get them to that sliding board, to slide them on the wheelchair, so it's like.
The main
trying to
thing is
get
you
them-
want, the main thing is you wanna unweight one side of their body
Mhm.
and really stick it deep
Yeah,
behind
yeah.
there and then angle
Yeah.
it. I wish I had a sliding board to show you, but just kinda angle it towards the chair and then once they're back sitting. Also, a lot of times they're skin to board contact, so I would put like a pillowcase.
Yeah, a chuck, something like that.
Chuck, something over the slide board, or some baby powder, make it slide a little better. But yeah, a lot of trouble we run into sometimes is the surface height is different. That's a difficult one. Again, if you do have a Hoyer lift, I would utilize it. I wish I'd brought a slide board, we could have did that. Didn't think about that one.
What about repositioning for a max assist patient? Like from side to side every 2 hours?
Yeah, again, go ahead and lay on me. Go ahead and get all the way. So again, I like to get both feet up like this and have them roll this way. I can control the body great with the knees bent. If the knees are flat like this, I'm having to work a lot harder to get him up. So let's bend the knees. So I can control them, and then if they can, to reach across their body towards me, reach for the bed rail, edge of bed. And then if they can't go that easy, by controlling the legs and reaching on this way, I could kind of get behind, stick my hand there, and just kind of use my body to pull. And then I could put the pillow here, make sure you have the pillow in reach, and then you could just put it here, just kind of roll them back like that. And the same for the opposite side. If you're having to do, patients way too low in bed, I would have, draw sheets, but that would be a 2-person job there. Or if you have the Hoyer lift, then you can use the Hoyer lift to help take them up. I would not try to do a draw sheet, trying to reach across the body. That's a big strain in your back, which I'm guilty I have done before, but it wasn't that heavy of a patient. Anything else? Sound yeah, the main thing is just to avoid twisting and rounding your back, because your discs are very weak, and if you're, even the slightest amount of weight, even 20 pounds just lifting like this can cause a disc to rupture, and then you're the patient. So,
One thing I wanna add, everyone in here, for home health, when it comes to a patient's, monetary, responsibilities, when it's, Medicare pays 100% of it. They do have a deductible, obviously, at the beginning of the year, everyone does. If they do have a supplement, that supplement will take over. When it comes to Medicaid, they cover it completely, but it does have to go through a, approval process for them, kinda like you guys. But it is taken care of by their insurance. So if you do see a patient that does qualify for home health services, their insurance will take over, just like they're paying you guys, they'll pay us. Okay, so I know a lot of them will ask that. If you say, hey, I think you're a candidate for home health, if that will be their first question.
Unfortunately, insurance dictates if you get something nowadays, but we do accept, Louisiana Healthcare Connections Medicaid. I know Medicaids are tougher to place with certain, agencies, so we definitely accept that one, and then we do accept others as well, so it really all boils down to insurance. So if y'all have questions about what insurances we take, I have my number on there, you can reach out to Tara, reach out to me, we'll be happy to be a resource for you.